Okay, we can start now. Sneha, please start.
Yes. Just a minute now. So good evening and welcome to all. This is Sneha from Clarnet, the dedication session assigned for the seamless experience. Clarnet is very proud to be a digital partner for this event organized by the Society of the Onco Anesthesia and the Perioperative Care. And our today's session topic is perioperative management of the orthopedic oncosurgical patients. So without further delay, I would like to take this handover to the session to Dr. Anjali Pingle ma'am. Over to you, ma'am. Kindly proceed for your talk. Over to you.
Good evening, everyone. Thank you so much for joining in. I know it's Navaratri and everybody's busy. So I would like to welcome all of you to this session. May I have the introductory slide for Dr. Sumitra Bakshi? I would like to introduce our chairperson, Dr. Sumitra Bakshi. She's a professor at Tata Memorial Hospital. She is interested specifically in pain and regional anesthesia, and in this field, she has a lot of research and some very contemporaneous lectures, which are lovely to hear, which are very research-based and evidence-based. And she has multiple papers on this at the moment. I would like to hand over the session to Dr. Sumitra. Today's topic, as we've already heard, is on orthopedic surgery, onco anesthesia for orthopedic surgery. Over to you, Sumitra.
Thank you, Anjali. Thank you for the kind introduction. So we are looking forward to a very interesting and interactive session with all our participants. Orthopedic onco anesthesia has a special position in the sense it is interesting. It's way different from orthopedic surgery in non-onco cases, and as we hear eminent speaker talk, we would get more idea about this specific case series. With no further delay, I will introduce the speaker, Dr. Bindiya Salunkhe, colleague in the Department of Anesthesia, Tata Memorial Hospital. We are fortunate to have been exposed to a varied variety of orthopedic cases, thanks to the surgeons who are very who have a well planned plan and do a very variety of cases in orthopedics. So let's hear the talk, and at the end of it, we hope to have an interactive session. So over to you, Bindiya.
Thank you, madam.
Start the evening.
Thank you, madam. So today, I'm going to talk about perioperative management of orthopedic oncosurgical patients. So what is different in oncological orthopedic procedure? It is seen in all age groups, most commonly in the younger age group, which is contradictory to the non-oncological, which is mostly the hip and knee replacement are seen in the elderly patients. Complex treatment strategies in extensive surgical excision is seen in this oncological orthopedic procedures. most of the patients are receiving chemotherapy and radiotherapy, which has their own implications. Pain severity is more compared to the non-oncological orthopedic procedure, and the massive blood loss is seen in most of the cases, which we'll be discussing. So, bone and soft tissue tumors can be divided broadly into benign tumor, malignant tumor, or metastatic tumor. Most common metastasis is from prostate and the breast cancers. Also, we see from other sites as well. Primary malignant bone tumors like osteosarcomas, chondrosarcoma, Ewing sarcoma, and myeloma are seen. 5-year survival rates have significantly increased in primary malignancy, around 50% in osteo and Ewing sarcoma, and chondrosarcoma up to 75%. And this improvement is seen because of the advances in the diagnosis with the imaging and in treatment with chemotherapy and surgical modalities. Due to the complex treatment strategies and extensive surgical excision aiming to the limb preservation, the anesthetic and perioperative management of this patient have become quite challenging. Preoperative consideration. Surgical procedure. What is the procedure we have to know? We have to discuss with the surgeon what is the extent of the tumor, or how much expansion is there, and what is the current treatment and current surgery we are planning for the patient. Chemotherapy and radiotherapy may have significant effect on the patient's clinical condition. Myelosuppression, that is anemia, thrombocytopenia, is most commonly seen post-chemotherapy in this patient. As per the NATA, that is a network of advancement of transfusion alteration, the recommendation of hemoglobin should be more than 12 in female and more than 13 gram % in male population pre-surgery. The diagnosis of anemia, if confirmed, should be diagnosed if it is because of myelosuppression because of the chemotherapy, it is nutritional, or because of CKD. Anything we have to replace. If it is nutritional, iron supplementation should be advocated. IV access may be difficult in this patient because of the multiple chemotherapy patient have received. Because of that, the IV access most likely is in difficulties. Large vascular tumors will be like pelvic tumors, hemipelvic tumor patient comfort. They require preoperative angioembolization to decrease the blood loss. This is one more different thing from the other cases. Preoperative pain medication, most of the patients can be, in case by the time they get diagnosed and come on table for the surgery, they may be already on the pre-operative pain medication. So during surgery, we have to take care of that. If patient is already on some fentanyl patch or some other medication, we have to optimize it, and we have to think ahead of it. PET-CT helps us in diagnosing the metastasis and in the most of the cases, and diagnosis is confirmed by open or closed biopsy. Risk of the high-risk patient should be identified, that is the older age group, type of primary tumor, and site of tumor, like a pelvic tumor, which I've already told you, or do surgery for the knee. Those are the high-risk tumor. Higher Charlson comorbidity index or blood transfusion the patient has received perioperative. These are the patients with a high risk. So in pelvic tumor, possibility of the major blood vessel and nerve root involvement is there with the pelvic venous thrombosis. This should be also taken in consideration while deciding about the regional anesthesia use, and also pelvic venous thrombosis if present. We have to think of the divided prophylaxis. Sacral tumor resection may involve a laparotomy for the anterior exposure, followed by the posterior resection and pelvic stabilization, and amenable to surgical staging. This has to be discussed prior with the surgeon, and we might have to change the positions of the patient intraoperatively. That has to be considered. If patient has a preoperatively dry cough and dyspnea, it should be, we have to differential diagnosis should be thought about the chemotherapy-induced lung disease, metastatic invasion, pulmonary embolism, and infection. These are something different symptoms which have to be taken care of. Chemotherapeutic agent, as we have already spoken about, the common chemotherapeutic agents which are used in the bone soft tissue malignancies are methotrexate with leucovorin in combination with doxorubicin, ifosfamide, and platinum. Cyclophosphamide, daptomycin, etoposide, vincristine, and anthracycline and alkylinating agents and taxanes are also being used. All possible side effects should be evaluated before going ahead with the surgery for this patient. Chemotherapeutic agents the different agents which I'm going to discuss about, like an anthracycline antibiotic like doxorubicin, daunorubicin, they have a high cardiotoxicity index. If patient has a prolonged QT prolongation is there, it can enhance it with the use of inhalation agents like isoflurane. Pulmonary fibrosis may be present. So if patient has received doxorubicin, we have to consider the patient, even if the patient's effort tolerance is good, we have to consider having a ECG and echocardiography for these patients. Tropomyosis inhibitor, that is etoposide, has side effects of pulmonary side effects like respiratory failure, interstitial infiltration, dyspnea, stomatitis, and peripheral neuropathy. Even if it is less 1%, we have to consider this while giving the peripheral nerve blocks or regional anesthesia. We have to always stage whenever we have a neuropathy as one of the side effects of chemotherapeutic agent, we have to consider regional anesthesia, we have to consider carefully. And we have to already document how much is the neuropathy in this patient if we are going ahead with the regional anesthesia. Vincristine again has a peripheral neuropathy, peripheral neuropathy as one of the side effects along with SIDH. So we have to think about regional anesthesia again. The electrolyte imbalance, if there is, we have to correct it and we have to take in consideration. Toxins like paclitaxel, doxycycline, they have a cardiac symptoms as well as a peripheral neuropathy or autonomic neuropathy. So we have to be more careful along with if patient is a long-standing diabetes and in the other comorbidities, we have to be more careful about this patient. Platinum analogs, cisplatin, carboplatin, these are more likely to cause a hearing impairment, visual impairment, encephalopathy, peripheral neuropathy. Nephrotoxicity is more commonly seen with the cisplatin. So, use of co-analgesis like we have to have a electrolytes pre-operatively for this patient. Plus, use of co-analgesis if there is already issue, we have to think about using NSAIDs or not in this patient. Cardiotoxicity, even if it is mild, if the symptoms are present, we have to evaluate it further. Hepatotoxicity also is seen in this patient. We have to watch for the hepatotoxicity and think about the use of paracetamol or NSAID for this patient carefully. So electrolytes and the peripheral should be done for all these patients. Then antimetabolites like methotrexate, they again have a decreased excretion of NSAIDs is seen in this patient. They have antifolate activity with the nitrous, acute encephalopathy, hepatic fibrosis, cirrhosis is seen, mucositis, pulmonary issues like pneumonitis or pulmonary edema, fibrosis are commonly seen with this agent. Alkalinic agent like ifosfamide, cyclophosphamide, they have a renal impairment. They also have a hemorrhagic cystitis is very common in this patient. So whenever patient is receiving this drug, we have to think about adequate hydration to decrease the risk of hemorrhagic cystitis. Cyclophosphamide also has a pseudocholinesterase inhibitor properties lasting for 3 to 4 weeks. So when we are using succinylcholine, we have to be careful in this patient. Also, hepatotoxicity, cardiotoxicity is seen along with. Actinomycins, like dactinomycin, has a hypocalcemia, mucositis, and hepatotoxicity as its side effects. So calcium as one of the electrolytes should be done in this patient. And other agents like tabectedin has hepatotoxicity, rhabdomyolysis with and arthralgias as one of the side effects of this. Whenever patient has received radiotherapy, this was about a chemotherapy. If patient has received a radiotherapy, the site of radiotherapy is of particular importance. If there is a chest wall irradiation associated with the fibrosis, it is associated with the fibrosis, impaired capillary permeability, and increased pulmonary vascular resistance, which may develop acutely or even after years after exposure. So we have to be careful with pulmonary edema is one of the complications which can happen when we have given anesthesia to this patient. This should be kept in mind. There is a mediastinal irradiation. If the primarily patient had a breast, this with now metastasis and has come for a surgery for that, then mediastinal irradiation may cause a cardiotoxicity. So we have to be more careful when it is combined with a cardiotoxic chemotherapeutic agent like daunorubicin is used in this patient. that surgical plan has to be known prior to going ahead with the surgery. So wide range of plans are can be there from the bone biopsy to the supramajor surgeries like hemipelvectomy. Bony biopsy anesthetists will come in picture when it's case of a pediatric population. In pediatric population, where mostly this is a non-operating room, we are doing this procedure as a daycare procedure. It's so patient will be have to give GA. Sometimes we have to go ahead with inhalation. So NORA and daycare procedure has to be, two components have to be taken care in this patient. And whenever we are taking a biopsy, and also the pain relief medication, whatever to be given to the patient should be prescribed along with. Other issues like major neurovascular dissection may be there. As I've already spoken about, hemipelvectomy can cause a major neurovascular dissection. So, in such patient, neuroaxial blocks or peripheral nerve blocks, we have to be more careful with this patient. Even if we are giving, activation of these blocks can be done post-operatively after knowing how much was the dissection, what is the extent, what is the nerve loss, or we can opt for not going for a neuro peripheral nerve, regional analgesia for this patient. Okay, so they have a preoperative. Most of these patients undergo preoperative angioembolization of the tumor if possible, whenever it is possible. But it should be taken in mind, the surgery should occur within 48 hours of preoperative angioembolization of the vessels, major vessel which is supplying the tumor. If it goes beyond 48 hours, the collaterals will be developed and the bleeding chances will be similar what it was without angioembolization. So that timing has to be it should be done properly. Other thing is blood conservative strategy should be there. When we see the patient first time in the pre-anesthetic checkup, we have to see the iron, what is the hemoglobin of the patient, what is the serum iron of the patient. As per that, we have to start with the iron therapy for this patient if required, build the HP prior to the surgery. Also, other blood conservative strategies can be established in this patient when we already know we are going to undergo a major blood loss. And regional anesthesia, as I have already spoken, is questionable in these cases. Extensive resections also have the similar problem. Joint replacement with cement will give rise, will have one of the major complication as bone cement implantation syndrome can be there, seen with it. So we have to be watchful during the cement implantation. Then other things are rotationoplasty and free flaps, which have come more in the picture with advance of the surgical advances. So free flaps or rotationoplasty, whenever we do, we have to maintain the good tissue perfusion pressures. The blood pressure should be maintained well for this patient. Normothermia should be maintained in this patient. We have to start warming the patient from the time of induction. The hematocrit of this patient should be maintained at around 30%. So this will balance both the viscosity as well as the oxygen transfer to the tissues or the flap. Normocarbia should be maintained in this patient as hypocarbia can cause increased pulmonary vascular resistance and decreased cardiac output, and hypercarbia can stimulate the sympathetic stimulation and will cause vasoconstriction. Regional techniques are of advantage in free flaps that it causes sympathetic blockage and vasodilation. So these are the major considerations which should be taken care of. Anesthetic techniques, general anesthesia versus regional anesthesia, or a combination of general with regional analgesia should be considered case-to-case basis. Per extremity tumors like brachial plexus, for upper extremity tumor, brachial plexus block is with the catheter, without catheter, is of more useful because it will provide us a good analgesia. It can be given with or without general anesthesia. Lower extremity tumors, central neuroaxial blocks with peripheral nerve blocks, along with again the same with general anesthesia for long duration cases. In case of major blood loss is expected, in case of free flaps are expected, in those patients we can go ahead with both regional analgesia with general anesthesia for this patient. Spine pelvic tumors mostly undergo under general anesthesia with the epidural or intrathecal morphine can be given as a pain for a perioperative postoperative pain management of this patient. Optimal patient positioning is a optimal patient positioning is required to facilitate surgery and avoid complications like blindness, nerve injury during the prolonged prone positions, especially with the prolonged prone position. So, multimodal or postoperative analgesia is mandatory and efficient physiotherapy and rehabilitation. We have to go ahead with a good physiotherapy and rehabilitation of this patient. So, analgesia should be optimal. Thromboembolic prophylaxis has to be given to all the patient once the perioperatively, and postoperatively can be started as soon as we know the bleeding chances are less in this patient. That time we can restart. Management of perioperative hemorrhage, we will go in discussion further with that, and bone cement implantation syndrome, which I'm going to discuss further. These are the things we have to consider in perioperative periods. So, intraoperative monitoring, what are the monitors which we are going to have for this patient? So, standard ASA monitoring should be done. It should be individualized depending on the case to case basis. How extensive is the case? What are the comorbidities with the patient? All these things will decide your monitoring. Standard ASA monitoring should be done. Invasive arterial pressure will be required in case when we are anticipating a major blood loss or cardiovascular comorbidities are present in the patient. Cardiac output monitor in high-risk patient, like if patient already has some comorbidities, or even including those which have received a chemotherapeutic agent which have cardiotoxicity is there, and which are shown to have the findings in an echocardiography. Thromboelastogram or rotation or rotem is can be monitored during massive blood loss. So it will help us in goal-directed bleeding control and coagulopathy management. Positioning of the patient is one more important thing in orthopedic surgeries. So multiple positions may be employed like supine, lateral, picture position, and prone position. Each position has this own implication. Optimal patient positioning is important to facilitate surgical exposure. Patient must be placed in the anatomical position. Whichever position you're placing, you have to see the hands are facing towards the patient. Patient should be in anatomical position with good padding at the pressure points and prevention of the compression and stretching of the related nerve injuries and prevention of the ocular compression. This has to be taken in any position. Brachial plexus injury is a very common injury which is seen in the orthopedic procedures, which get because of a overextension in the supine position. Prone position, we have to be more careful as it can cause a compression of the eyes, the arm, abdominal compression, breast can be compressed, and genitals have to be taken care, especially in the males. All this pressure and the pressure points, obviously, they all have to be taken care and well padded. Prone position is associated with increased intraoperative hemorrhage, increased risk of blindness, nerve injury, and screen breakdown. If it is more seen in case of obese patient, and the procedure when it's lasting for a prolonged duration, more than around 10 or more than 10 hours. With prone position, if the abdominal compression is there, if your abdomen is not left free, then it will cause the venous congestion in the epidural spaces, and that will cause a bleeding in case of major bleeding in case of spine surgery. So that has to be taken care of. The American Society of Anesthesiologists Task Force on Perioperative Blindness has recommended the high-risk surgical procedure patients' head should be at the neutral forward position at the level of the heart or slightly above heart. This has shown to decrease the chances of the ocular trauma. Next is the hemorrhage or the blood loss, perioperative hemorrhage. So what are the factors we can take care of? One, we have to have the hemoglobin of preoperatively at the good range of the patient, like more than 12, more than 12 in female, more than 13 in male. This will give us a good leverage for the to maintain the blood loss. Preoperative, if a major tumors are there, preoperative angioembolization of these tumors, which I've already spoken about, will be of great help. But within 48 hours, this patient should come on the table for the major dissection. Otherwise, the revascularization will occur, the collaterals will develop, and that will again cause a major blood loss. Next is what are the different modalities we can use? We can have a autologous transfusion in this patient. Patient can donate his blood preoperatively, and the same blood can be transfused to the patient intraoperatively. But for this, patient should have a good hemoglobin, and it should not cause the anemia in the patient because of the same. So that has to be taken care of. Another thing is cell salvage. It was said to cause the increased risk of tumor dissemination, was considered prior in the old thought. Now, they have seen that in a prostate and urinary bladder and gynecological surgeries, when the cell salvage was done and with the use of leukocyte depletion filter, they have seen that the hello, disease-free survival rate is equal to in both the groups, as well as they have the cancer patient, the tumor, whenever they tested this blood, they saw that after leukocyte depletion filter, the tumor cells were fully removed from the blood. A systemic review by Kumar et al. Has shown the intra-op cell salvage with the leukocyte depletion filter not associated with a higher risk of tumor dissemination or metastasis. So, but in orthopedic surgeries, we have not yet having any consensus on this. Another thing is acute normovolemic hemodilation. Patients with a good hemoglobin, patient's blood can be collected pre-operated, and the same blood which could be replaced with the crystalloids or colloid, and the same blood could be transfused to the patient when the blood loss starts. One more thing is antifibrinolytic drugs like a tranexamic acid, which is mostly used in the orthopedic cases, which helps in decrease in the blood loss. Preparations when we are heading ahead with the blood loss, when we know that the major blood loss is going to happen, we have to have a good wide bore cannulas to the patient. Invasive monitoring has to be initiated prior as well. It should be already initiated, and rapid transfusion facilities should be available. Adequate blood products should be seen and that they are available. We can utilize the ROTEM or tag in this patient to know what blood products we have to transfuse. All these things has to be taken in consideration. Role of regional anesthesia and analgesia is very important. Epidural analgesia provides superior pain control and patient satisfaction compared to the IV PCAs with opioids. So epidural analgesia also known to reduce the intraoperative blood loss, opioid requirement, surgical stay, the stress response, thromboembolic phenomenon, which is most commonly seen with the orthopedic procedures, cardiac arrhythmias, pulmonary complications like atelectasis, pneumonia, good pain relief, and early return of the bowel functions is seen. So it can be epidural helps in early mobilization of the patient as well. So all these things will help the patient post-op patient care as well. Peripheral nerve blocks are valuable alternative or adjuncts to the general or neuroaxial anesthesia. Advantages being they are safe anesthetic modalities associated with minimal hemodynamic and respiratory changes. Prevention or treatment of Fenton rim is present with this. Continuous catheter gives the excellent analgesia with the minimizes the use of opioid and volatile anesthetic requirement and reduces the stress response to the surgery. Neuroaxial and peripheral nerve blocks provide excellent analgesia, but caution is required in patients with pre-existing neurological deficit. If still we are planning to go ahead with the regional anesthesia, we have to document what is the patient has, whatever the deficit is pre-existing. If intra-op we are expecting that there could be a nerve handling, nerve damage, then there might be in those patients we need not initiate the epidural or a block could be placed, and we need not initiate it till we assess the nerve function post-operatively, and then we can initiate. Because if there is a massive blood loss, there could be coagulopathy, and the reinsertion of the epidural will be difficult post procedure. That's why we should initiate it prior. In case of pre-existing peripheral nerve, due to mechanical compression, infiltration, chemotherapy, the axonal flow kinetics and neurofilament architecture associated with the peripheral nerve blockage may aggravate the nerve function. And we have seen the prolongation of the block or neurotoxicity in these patients. Pain management, acute postoperative pain management is extremely challenging in this patient because the extensive resection in this patient. So, pain relief, inadequate pain relief will cause poor rehabilitation, mobilization will be delayed, development of chronic pain syndromes in this patient, and other complications like immunosuppression or the hyperglycemia is seen. Multimodal analgesia is the key for all these patients. Multimodal analgesia is based on the principle that combining the analgesics with the different modes or sites of action will result in a better pain control and less side effects from opioid sparing. Preemptive analgesia, that is, refers to the administration of pain medication or performing procedure before the surgical incision to prevent surgical pain. So if we have placed a block prior, all our opioid are optimized prior to the incision, that is important. So it is intended to prevent peripheral and central hypersensitivity, decrease the incidence of hyperalgesia, and reduce the intensity of postoperative pain. Multimodal analgesia, as I have said, is a key. Central neurological, regional, or local analgesia is one of the modality. Other is the systemic analgesics. So it could be opioids, is the mainstay of postoperative pain management, but it has various side effects like nausea, vomiting, respiratory depression, urinary retention, pruritus, and the risk of addictions. Paracetamol, acetaminophen, it is for mild to moderate pain, and it can be given along. Can be given as a part of multimodal analgesia. Both the NSAID and acetaminophen, they inhibit a prostaglandin synthesis. NSAID, COX-2, if selective COX-2 is used, it has a lesser side effect, which are seen with the COX-1, like bleeding, GI ulceration, renal dysfunction, which are not seen with, less seen with the COX-2. Gabapentin or pregabalin, anticonvulsants like gabapentin, pregabalins, they can be used especially for the neuropathic pains, fentanyl pain, and along as a co-analgesics along with the multimodal analgesia. There's the side effects of sedation, visual disturbance, giddiness, dizziness, headache. These are the side effects which have to be considered. And NMDA receptors can be also antagonists can be also used like ketamine and magnesium, which are specially used in the spine surgeries, have shown a good post-operative pain relief in this patient. And mostly refractory pains are this modality used for refractory pains when other modalities are used and they are of less less effect. At that time this modality come into picture. Steroids, they are used for the postoperative pain as well as nausea vomiting management. They open several mechanisms like anti-nociceptive effect at the spinal level, prevent the production of the cytokines and inflammatory pain, and inhibit the production of inflammatory prostaglandin, and thus causing the decrease in the pain. Next important thing which we have to know about is thromboembolic prophylaxis. Cancer itself carries a fourfold increased risk of the thrombosis, while the major orthopedic surgery is also independent association for the associated with the high risk of DVT. So when both come together, the chances of the DVT are very high. So the reported incidence of pulmonary embolism in cancer patients undergoing musculoskeletal surgeries is 0.6 to 11% in with the different studies, and it has shown that both mechanical and anticoagulant when it's given to the patient, mostly we use low molecular weight heparin. The incidence have come down to 0.6 to 1% of P. So the thromboembolic prophylaxis, low molecular weight heparin is most commonly used Claxon, or heparin, unfractionated heparin can also be used. Bone cement implantation syndrome. This is seen in both orthopedic as well as non-orthopedic surgeries, as well as the tunicate, use of tunicate is seen in both the cases. So which have to be this I'm going to discuss now. So bone cement implantation, it is a potentially fatal complication involving the pressurized bone cement. The ability to predict, recognize, and manage bone cement implantation syndrome in perioperative setting is important for every anesthesia provider. So we have to know what are the factors, what is the characteristic. If there is a hypoxia with or without hypotension, and if patient is, the case is undergoing under regional anesthesia, patient is becoming drowsy, loss of consciousness, these are the things which are indicating at the time of bone cement implantation, bone cementing. These are the things which are telling you this patient might be having a bone cement implantation syndrome, and you have to act quickly. The incident is in orthopedic procedure around 20%, and the incidence of severe reaction causing a collapse of cardiovascular system, cardiac arrest is 0.5 to 1.7%, as high as 0.5 to 1.7%. Which are the high-risk patients for this? There are the metastatic bone tumors or pathological fractures, pre-existing chronic pulmonary disease, pulmonary hypertension, cardiac morbidity, high ASA scores, or in patients who are receiving diuretic warfarin, they are at higher risk. The cardiovascular changes present can be variable. Most commonly, a reduction in mean arterial pressure, reduction in the stroke volume, reduction in the cardiac output. This will cause a reduction in cardiac output, and increase in pulmonary vascular resistance, causing the reduction in the right ventricular ejection fraction. ATCO2, arterial wave from central venous pressure, transesophageal echocardiography provides a very good information. ATCO2 will drop, arterial flow will suddenly start dropping down. In the transesophageal echocardiography, we will see the or the RV-RA dilatation in this patient. So if we have, we can, in a suspicious cases, we can go ahead with the TE in this patient. So whenever there is a hypotension, desaturation, and arrhythmias, we have to think about the bone cement implantation syndrome may be the thing which has come into picture. So in the 3 stages have been of this have been classified by Donaldson et al. They are stage 1 being hypoxia of less than saturation dropping less than 94%, with decrease in systolic blood pressure of more than 20%, and no loss of consciousness. Grade 2 is saturation dropping less than 88%, with this systolic blood pressure decreasing more than equal to 40%, and there is a unexpected loss of consciousness. And grade 3 is cardiovascular correct, requiring CPCR. Pathophysiology, it could be, we don't know exact, but there are 2 theories. One is embolic model, and another is multimodal model. In embolic, it is like during the cementation, the process is inserted, the cement gets it is pressurized with the force in the space between the bone and the marrow. So when the cement expands, the air, debris, the fat, marrow, whatever is between this will get pushed into the circulation from the major vessels of the marrow, and because of this even the cement component, and this will cause this will reach the pulmonary circulation, which will reach the heart and cause the pulmonary embolism, okay, and which will cause the right ventricular dysfunction and the hypotension. This is one mechanism of embolic model. Second mechanism is multimodal model, which is histamine release, hypersensitivity, or component activation. So with the bone cement which is used in methacrylate, when it is seen that the orthopedicians have used in them, they have studied some components and they have seen the components which are more for anaphylaxis are been seen in those surgeons. So it is saying that methacrylate is one of the itself as a it's as a and it is an anaphylactic agent. It acts and it causes vasoconstriction and bronchospasm, and this will cause the increased pulmonary vascular resistance, VQ mismatch, hypoxia, and it will cause a cardiogenic shock and right ventricular failure. The safety guidelines reducing the risk of cemented hemiarthroplasty for the hip fracture in 2015 got published by Association of Anaesthetists of Great Britain, Ireland, British Orthopaedic Association, and they have given some preventive measures like anesthetic techniques. What can be done to prevent the bone cement implantation is increasing the inspired oxygen concentration in all patients at the time of cementation, avoiding intravascular volume depletion, increasing the blood pressure prior to the period of the increased bone cement implantation risk. Before cementing, you can see. Surgical techniques are lavage of the bony canal prior to the cement insertion, pulsatile lavage use of suction catheter to depressurize the intermedullary canal prior to the cement insertion, and retrograde cement insertion. Start from behind, come in front. It will cause the this could be used as a preventive measure. Management, it should be aggressive resuscitation of this patient, 100% oxygenation should be given, hemodynamic monitoring should be invasive hemodynamic monitoring should be initiated in this patient with the resuscitation continuation if with ACLS guideline. Fluid resuscitation to maintain the right ventricular preload and inotropes to support the ventricular contractility are recommended. Vasopressin should be used like this vasopressin like phenylephrine and noradrenaline. They'll cause norepinephrine. They'll cause peripheral vasoconstriction. This will cause the increase in blood pressure, support the coronary arterial blood flow, which will improve the myocardial perfusion and contractility. So next we are going to talk about the one more important component is the tourniquet use. Tourniquet use, it is a constriction or a compression device used to control the venous and arterial circulation to an extremity for a period of a time, a particular period. Tourniquet cuff, there are specific things which you have to know about the tourniquet cuff. It should be at least 3 inches, but overlap at least 3 inches, but not more than 6 inches. Too much overlap will cause the pressure, will increase the pressure and will cause underlying soft tissue damage. And too less the overlap will not be a adequate tourniquet will not form. Unexpected release or inadequate constriction will be seen. The width of the cuff should be wider than the half of the limb's diameter. Wider cuffs minimizes the risk of injury to the underlying tissue by depressing the pressure over the greater surface area. And they are said also to occlude the blood flow at the lower pressures in adults as well as in children. They should be positioned on the limb at the point of the maximum circumference. These are the 3 points which we have to consider. Then there is something called limb occlusion pressure. How much pressure we should, with what the tourniquet should be inflated. So there is something called a limb occlusion pressure. It is defined as the minimum pressure required to stop the flow of the arterial blood into the limb distal to the cuff. So we have to inflate the cuff and check the peripheral pulse and see if the arterial flow has stopped, and that should be considered as the LOP. Then after that, for at 40, if the blood pressure is whatever the LOP is less than 130, at 40 millimeter, and that should be what you have to set the tourniquet pressure. If it's 130, 190, add 60 to this pressure, and that should be the thing. In more than 190, add 80. And in pediatric patient, 50 has been adding 50 has been recommended at any pressure. So these are the recommendations for LOP. The safe time, what is safe time? We will still not come into the thing of what is the safe time for the tourniquet, for how long we can apply. So it should be between 1 to 3 hours. So generally not exceeding 2 hours. but absolutely not more than 3 hours. In pediatric patients, inflation time of less than 75 minutes has been recommended for the lower extremities. Give the antibiotic prophylaxis we have to give. It has to be given at least 5 to 10 minutes before the tourniquet inflation. And if we have to repeat, it has to be repeated the deflation of tourniquet. How long after whatever the 2 to 3 hours of your tourniquet if it remain after that for the good penetration, tissue penetration. What are the complications related with this tourniquet? Why we say we can't go beyond 3 hours? So we should be careful after 2 hours. So they call the nerve injuries. They call multiple injuries, nerve injury, muscular injury, skin injury. Nerve injuries are related with the application of the tourniquet application range from paresthesia to paralysis. The incidence is being 1 in 62,000 in upper limb and 1 in 37,000 in the lower limb. The overall incidence of permanent damage but is very low, 0.032%. Now injury is maximum at the proximal and distal edges of the curve where the shear stress is the greatest. Now injury is more common in upper limb. In upper limb, radial nerve is most commonly affected, followed by ulnar and medial nerve. And lower limb, peroneal nerve is most commonly affected now. Pathophysiological thing we can see it is a combination of compression and ischemia. Compression of the nerve by the curve causes the intraneural microvascular abnormalities in the part of the nerve adjacent to the curve. This will lead to edema, results in the compromised tissue nutrition and axonal degeneration. The prognosis of the tourniquet-induced nerve injuries is generally good. Permanent deficit is very less, which I've already told you. And most injuries heal spontaneously within 6 months. But we have to monitor this patient. Muscle injury, it is a combined for ischemia and mechanical deformities of the tissue. Tourniquet-induced ischemia and reperfusion generate hydrogen peroxide and causes increased xanthine oxide activity in local and systemic blood, which contributes to the injury of the skeletal muscle, myocardium, kidneys, lung, lung after ischemia perfusion. So we have to that is the why we have to limit the time of the thing. And skin and vascular injuries, because of the pressure again of the cuff, it is most seen in the children, obese, elderly patient, and peripheral vascular disease who have. And if it is youth, poorly fitted, and used for a prolonged period, the tourniquet is used for prolonged period. These are the highs. Cardiovascular effects which are seen with the tourniquet can be seen in all the stages of tourniquet, from exangiostia to the deflation. So it can be during inflation, the blood volume and systemic vascular resistance that ultimately cause a transient increase in the central venous pressure. After 30 to 60 minutes of inflation, we can see the heart rate and systolic and diastolic blood pressure rising. This could be because of the tourniquet pain, and which will mostly doesn't get relieved with any analgesics or increasing in the depth. It gets relieved only when the tourniquet gets released. Tourniquet inflation again causes a sudden drop in the central venous pressure and mean arterial pressure. This hemodynamic changes because of the both combination of the shift of the blood volume back to the limb and wash out the metabolites which have been anaerobic metabolism, whatever is the point that has caused the metabolite whichever to wash out from the ischemic limb into the systemic circulation. Respiratory effect mostly seen during the tourniquet deflation. You will see the transit increase the end-tidal carbon dioxide because of the efflux of the hypercapnic venous blood and metabolites in the systemic circulation. Hematological effects, something important. Tourniquet use induces the change in both coagulability and fibrinolysis. Inflation during surgery associated with the hypercoagulable state due to increased platelet aggregation and stimulation of the coagulation factor caused by the tissue damage and catecholamine release in response to the pain from the surgery and tourniquet pain. The brief period of increase in fibrinolytic activity is seen due to the release of the tissue plasminogen activators, activating the anti-thrombin 3. This will and thrombomodulating protein C anticoagulant system after the deflation of tourniquet. This is the possible cause for the increase in fibrinolysis for the post-tourniquet bleed. And this increase in fibrinolysis is maximum 15 minutes and returns to preoperative levels within 30 minutes of tourniquet release. Tourniquet pain the mechanism is not, etiology is not well known. It can be because of the cutaneous neural mechanism, but it is poorly localized, dull, tight, aching sensation at the site of tourniquet, and more seen with during general anesthesia, where you will see the increase in the heart rate and mean arterial blood pressure. And under general anesthesia, 53 to 67%. The tourniquet cuff depletion is one more important factor, because tourniquet cuff depletion causes release of anaerobic metabolite to the systemic circulation. This will cause a hypotension, metabolic acidosis, hyperkalemia, myoglobin anemia, myoglobinuria, and it could cause renal failure. Again, it depends on the duration, for how long, and how much is mostly seen with the lower limb surgery. It is also known as myoneuropathic metabolic syndrome, and it depends on the size of the extremity, duration of the tourniquet being inflated, and overall physiological status of the patient. So to conclude, oncological bone and soft tissue surgeries are more extensive surgeries compared to the non-oncological. Pre-operative evaluation must stress on chemotherapy and radiotherapy, whatever patient has received, even it is not for the primary malignancy. Major blood loss should be anticipated depending on the site of the tumor and nature of the tumor. DVT prophylaxis is must, and adequate management is must to minimize the post-operative increase the patient mobilization, patient rehabilitation. Thank you. Over to you, madam.
Bindiya, that was an excellent presentation, a brilliant compilation of the key points that one needs to remember during the orthopedic oncosurgeries. I mean, I think you've covered almost all points. We have no queries in our chat box. Nevertheless, I'll move our attention to a few practical points till maybe the participants warm up and share their queries. We'll just rediscuss practical points, which we'll elaborate on that. So coming back to, you mentioned that regional analgesia we have to discuss with the surgeons, and it is in extensive surgery, it's best done at the end after complete resection of the tumor. So in case if there's some nerve handling, we can, again, the surgeons and the anesthesiologists can weigh the risk and benefit of regional techniques. So assuming you are doing a major surgery and you do not have a regional backup, or you do not have a regional technique, can you elaborate on the practical points that you would do as a surgeon has the cautery or the knife in hand? That's one time where the surgical people look out for the blues on the head end. So can you just elaborate and discuss again the practical points that you would do at the head end, at the anesthesia end, to maintain a good hemodynamic parameters for the surgeons to operate?
Preemptive analgesia, which I have already spoken about, is the most important. So before the surgical, even the tourniquet inflation, we have to see to that we have given a good preoperative analgesia. If we are not expecting a major blood loss, NSAID can play a role at this point. Okay, opioids, if we are has to be given at this point, before inflation of tourniquet or before the incision. We have to see to that our blood pressure is maintained in the good range. It should not be the blood pressure should not be very high. It should be in the normal range pre-incision. So that will again help in the minimizing the blood loss. If we have a regional anesthesia can be used, yes, that should be initiated prior to the insufflation. That is what we say, or incision.
Right. Sometimes even drugs like dexmedetomidine now that brilliantly helps in getting the heart rate down, blood pressure down, and gives you a good operative condition, a little of propofol at incision. That really helps. Now, saying all that, I mean, blood loss sometimes becomes inevitable because of the numerous neovascularization that occurs around the tumor. Now, with respect to blood loss and management, you did mention about TEG, but sometimes that may become impractical in a case of ongoing loss, because TEG's parameters, again, there's a 20-minute wait period. So now, can you elaborate on the practical points and how you manage a case of a hemipelvis? What are the things that you keep ready at your end before the start of the event? How do you call for the blood products? Because that's very important to have a coordinated or a pre-planned, the pre-planned action action plan in your head and as to when you will call in for FFP, when you will call in for the other products. So can you just elaborate on the practical things that you do in a hemipelvis, before the start of the loss or during the loss?
So, one thing, good analgesia should be given prior to that, so the blood pressure remains in a normal range. Or when the blood loss starts, we have to see to that before even blood products have not reached, we have to give colloid or the crystalloid to maintain the perfusion till the time blood comes in hand. Blood products, we 1:1 should be the ratio. Most of the time, it is like in case of the massive blood loss. Same we have to follow here also. We have to have a wide bore cannulas for this patient, IV line, so that the rapid transfusion is possible. We should have a rapid transfuser available with us in a operation theatre. Sometimes cyanide of vasopressor may be required to maintain the mean arterial pressure till the time we tide over the crisis of the hypovolemia.
So just again for the benefit of our participants, and I'm hoping that anyone who have any queries are writing it up on the chat box so we can still pick it up. So to elaborate, an invasive arterial line is a must for these cases. You should have at least 2 large bore lines. Keep your in rapid infuser bags ready. That is in addition to the ones you have for your arterial line, right? That's very.
Also, I will say that tranexamic acid should it plays a one more important role. We can go ahead of it when we know it is a major surgery. We have to keep the calcium ready for this patient after the massive blood transfusion. We know that with hypocalcemia, that has to be ready and available for us. Magnesium should be available in the OT so that replacement can be done at the right time.
Right. So here again, the key point I wanted to highlight is that, like you rightly said, when you're expecting massive loss, initially you could, based on the hemoglobin, start with non-blood products, but later on it is replacing blood for the ongoing loss. One must account the delay of acquiring blood products like FFP. That would be probably varied based on institute, and there has to be an approach of foresighting that what would be the events half an hour later. So if I think I'm going to reach 1 blood volume loss, I should activate or call for the blood fresh frozen plasma much in advance, because there is a 20-minute or a half an hour waiting time for thawing these products. So that is very important to get the entire time frame with respect to blood loss, and you have to anticipate the need of these blood products much in advance. Tech may help you later once the specimen is out and you're looking at the entire parameters, and if the surgeon says it's a little loosey, you can look at all these tests to decide on whether you need more or any specific kind of blood products. But yes, during these massive surgeries, you have to anticipate and keep your blood products ready. So there may be even a need to send in a requisition for more cross matching. That's not unusual in a hemipelvis, that whatever blood has been reserved earlier, you might just run off. So you have to anticipate all these and keep it well coordinated with the blood bank. Right. Saying that, can you elaborate a little about estimation of loss? That's one thing where most of the residents make an error, is estimation of loss, because it's blood loss is so easily underestimated in these surgeries. So like in addition to the Gospis, suction drains, what is important is to get your focus on the surgical field. There could be a lot of loss going under the drapes onto the surgical gown, and that could be a major cause of underestimation of blood loss. So that would be important. You rightly say that calcium should be called in, or it should be administered along with, in a case of rapid transfusion, with every blood that has been administered rapidly, maybe calcium should be given, and a sequential or a repeated arterial blood gas monitoring to help you about the electrolyte imbalance. Now let's get back a little. I still do not have any queries on the chat box, but we'll take one last query that's that's one of my favorite points, is the perioperative analgesia. You mentioned that many of these patients could be on preoperative painkillers. So if you have a patient who has been on multiple or on opioids preoperative and coming in for an orthopedic surgery, to make it simple, we are not expecting major loss. What all things would you do at various steps to ensure that he has got good pain relief at the end?
I will prefer to go ahead with a regional anesthesia for this patient. Regional anesthesia, neuroaxial or peripheral nerve catheter is of very important, very essential for this patient. But opioid should be continued, I would say. If fentanyl patch is going on, that should be continued. So the withdrawal symptoms don't come immediate post-operative period. It should be slowly withdrawn after the over a period in the when we are monitoring the patient for post-operatively. So one thing important and say multimodal analgesia and say paracetamol should come in play earlier. The opioid which is going on should go on. We might have to hike up. We have to go ahead with the more opioid compared to what patient is receiving. Patient may be having morphine TDS 10 milligrams. So we might have to go ahead with the morphine in this patient. Plus, yeah, and regional, I will say that will play an important role.
Right. Yeah. So, and here again, I wanted to highlight in when you're talking about multimodal, especially if you have a patient who has been on opioid medications and coming in for an orthopedic surgery, there could be a role of giving gabapentin preoperative. It would be important to consider giving either dexmedetomidine intraop or ketamine based on your hemodynamics, because that would definitely play a role in getting the pain down in the post-operative period. We do have a question for us. Let me share it with you. Yeah. Does tranexamic acid increase the incidence of DVT in orthopedic malignancy?
So whenever we are expecting a major loss in those patients, we should case based. We should go ahead with the tranexamic acid. We should not be just giving for, if we are using a tourniquet in those patients. I will not advise, because yes, it increases the risk, and orthopedic surgeries are at a higher risk of DVT. But it will it doesn't cause the aggregation. It doesn't cause. So I think it should be case to case basis. When major losses expected, it can be used.
Yeah, I completely agree with you. A single dose of tranexamic given intraop doesn't really increase the incidence of DVT in the post-operative period. Yeah, and when a tourniquet surgery is planned, we're really not looking in for major losses. So in those cases, there need not be a need to administer tranexamic acid. But in a major surgery like a hip, it could be used with, it could probably help in reducing the blood loss. So we don't routinely do in our centers. So I do not know whether it is a it should be a completely one strategy that should be relied upon. But yes, tranexamic acid could be used in major surgeries, and intraoperative use does not outrightly increase the incidence of DVT in orthopedic malignancy. Do we have any other question? Yeah, there are two more questions for you. What is the role of permissive hypotension during blood loss?
Permissive hypertension again depends how much you are saying is a permissive. Up to 20% from the baseline is allowed. Less than that, it will again cause the major organ perfusion is decreased. So it is not advisable to go for more than that. So we have to keep the blood pressure within normal range only. Up to 20% should be fine, not more, less than that for a longer period.
Right. So hypotension is no longer used in the intraoperative period. Yes, but you're right. Keeping the field controlled heart rate and controlled blood pressure is what is really we are targeting at. And that's when we, even agents like dexmedetomidine or propofol infusion can help you in getting such stable hemodynamics during the surgery. The next question is, self-salvage and pre-op autotransfusion techniques are known to reintroduce circulating tumor cell and disseminate cancer. So a little elaboration on
yeah, so that's what I discussed about, because there are few studies, meta-analysis, systemic reviews they have done. So they have seen that in urology, prostate, and gynecological surgeries, they have done a and when they cell salvage, when they have used the leukocyte depletion filter, to the filter, they have tested the blood for the tumor cells and they have said zero tumor cells. The spire survival, when it was checked, it was seen that it was similar in the patient who has received a cell salvage and who has not received received a not autologous blood transfusion in those patients. So, but in orthopedic surgery, I didn't get any proper study as such. If it can be translated here, that's what I feel different.
Right. So there are no more queries there, and saying that, I would once again like to thank you for such a wonderful presentation today.
Thank you, madam.
So thanks.
Hi. Can I just add? Thank you, Bindiya, so much.
Thank you,
And many thanks, Sumitra, for guiding it so ably. I just wanted to say about cell salvage that, you really need to be ready with it. Meaning it can't be a sort of an afterthought or something that you will, because most of us, I don't know, does anybody actually own a cell salvage thing? You have to ask them to come in with it, right? So
you can't do it.
You have to pre-plan saying that,
Absolutely.
you're going to, yeah. And maybe this has already been discussed. I just had one question. For the mega prosthesis, how long do you keep your epidurals in?
Okay. Bindiya, would you like to take that?
In our institute, we have a protocol to keep it at the post-op day 4. We can extend it to 5, but we don't go mostly beyond that. Because of the infection rates, they are already immunocompromised. Infection rates could be the thing. So to avoid that, we don't go. What do you say, madam? So I think Sumitra madam is a better person to talk on it.
Right. So it would not really depend on what kind of prosthesis is coming in. What would decide how long the epidural would go would probably be as how aggressive is ambulation planned. So sometimes with the mega prosthesis, ambulation could be planned very slow and gradual. In those cases, keeping the epidural for more than 48 hours is futile. We get it out early. If there is, if they are very aggressive there, and even if we are saying they're aggressive, they don't really start weight bearing on that area for a week or so. It would be non-weight bearing ambulation. So we have seen that there is really no need to continue the epidural for more than 48 to 72 hours. So in fact, this is one area where we get our epidurals out relatively early.
Okay, so we have a slightly different way of doing this, because our surgeons tend to mobilize after 72 hours. And we tend to leave them in for 6 days until the patient is mobilized. So I think the practice most probably varies from institute to institute. I also wanted to ask about the use of albumin as a volume expander. Do you go in for that?
Okay.
No.
Bindiya?
We mostly don't use albumin as a warning expander. We replace with the colloids, some other albumin with the cost. We mostly don't go for this type of surgery. Fistulars can be replaced prior till the time we get a blood product, but we don't use most of the time.
Okay, thank you so much. Thank you, Sumitra. I'll hand over to you.
Are there any other queries? Let's check it out before we. Okay, there are no more queries there. Right. Due permission from everyone, Dr. Indira would like to add something.
Yeah, I just wanted to ask you about, did you have any incidents of embolism after the tonic depletion? Because I did have one experience and then I lost the patient actually. It's not only, I think they are more prone for even thrombus, but also air embolism in these cases. So I just was wondering whether what is the incidence about embolism after tonic deflation.
Come across any literature for that, madam? Actually.
Actually, embolism after tumor deflation, I don't think it has been very common because
Tumor, not tumor, madam. Tourniquet.
after tourniquet deflation, embolism, I don't think it's been common. Maybe there would be some rare case reports because by and large on tourniquet release, you have the field getting flooded immediately. So embolic with respect to tumor embolism happening at this point, I'm really not sure that would happen. No, I'm really not sure. Yes, during bone cementing, that could happen, especially if your patient is hypovolemic, they are long bones. There has been, like as Dr. Bindiya has already elaborated, it has been a metastatic bone disease. That time during cementing, you could have embolism occurring there, but during tourniquet deflation is something which...
What I've found in these patients, madam, is that because of the tumor metastasis or whatever, sometimes they are on a post-op immobilization, they have CAS, and I don't know how many of your patients actually have a Doppler done if they're prolonged immobilization pre-op. So tourniquet in those kind of patients, in spite of thromboprophylaxis, I have actually looked up literature, and there is a significant incidence of microemboli after tourniquet deflation, and sometimes it can actually lead to major embolism also. So that is one thing I wanted to emphasize, that tourniquet deflation, apart from the sudden, return of blood flow into the lower limbs, which causes the hypertension and also the metabolites, this also should be kept in mind.
Yeah, so to add to it, in patients who are high risk and who have not been mobilized for substantial time before they come in for surgery, yes, that's something that we need to keep in mind. But per se, if in absence of that, if the patient is undergoing a tourniquet surgery for an orthopedic malignancy, I don't think that is an additional risk. But yes, an immobilized patient who has had or a bad tumor there with which could be compromising the vascularity lower down, that should be considered. Yes. Any more comments from anyone? More questions? All right. Then with everyone's permission, should we call it a day? It has been an excellent presentation from Bindiya. And thank everyone for making it so interactive.
Thank you.
Thank you.
Thank you.
Thank you so much, everyone. Thank you.